Hi, welcome. My name is Ronya. I'm a peer mentor here at Arthritis Pain Support and Emerge ACT. And today I'm going to be talking about considerations for ME/CFS and long COVID in physiotherapy. Um, this kind of group of clients, if you may see anybody who's got ME/CFS or long COVID, they're quite a complex group, very, very diverse, and it have got some kind of unique considerations. So I'm hoping that this will be helpful for anybody who sees these clients in physiotherapy, potentially in other allied health professions. I myself have got lived experience of ME/CFS and long COVID and other chronic illnesses. So I spend my working days connecting and supporting other people with ME/CFS and long COVID and similar conditions like fibromyalgia. I don't practice. I'm not a physiotherapist. I, however, have worked in physiotherapy and allied health practices as administration support for the last 10 years. So some of this information is based on my own understanding of physiotherapy. I've consulted other physiotherapists and have relied heavily on other sources available for physiotherapy in this realm as well. But anyway, let's get started. So just a little bit about Emerge ACT before we get started. We're a non-profit for people living with ME/CFS, long COVID, and other complex and fatiguing illnesses in the ACT. We're part of a consortium of three different organisations, so Arthritis ACT, Pain Support ACT, and then Emerge ACT. As part of our organisation, we do have physiotherapists and exercise physiologists in clinic who treat some of the complex clientele that we see. So I have consulted with them a little bit on this presentation as well. Primarily for Emerge ACT, we run peer support groups. We provide mentoring, so again, peer mentoring, and a lot of self-management and pacing education for members so that they can improve their own situation, their own self-management. All of our staff and volunteer peer mentors have lived experience of either ME/CFS, long COVID, or fibromyalgia, or often additional diagnoses as well. So there on the right is our wonderful group of staff and volunteers. So the big question is, what is myalgic encephalomyelitis or chronic fatigue syndrome, which we'll be calling ME/CFS, and long COVID? When we're talking about ME/CFS and long COVID, I think there's a lot of misconceptions or misunderstandings about exactly what those conditions are. So I'm going to, first of all, give you a bit of an overview. So ME/CFS is a complex neuroimmune disorder that is often precipitated by a trigger. So we're talking an infection is very, very common. So a viral or a bacterial infection, some sort of other illness. Vaccination seems to be a bit of a trigger, particularly recently. Physical or psychological trauma. Often people have an onset after a major injury, like in a car collision or something like that. But also sometimes the trigger is unknown. Sometimes it can just gradually come on and we're not sure exactly what precipitated it. There is a really big issue in the realm of ME/CFS that we don't have good quality research. That is improving very, very slowly. But overall, for the number of people that it impacts, ME/CFS is a highly underfunded condition. Now, the key symptom for ME/CFS is post-exertional malaise or PEM. We will be talking about exactly what that is later on in this presentation. It is highly disabling. So even mild ME/CFS can be classed as somebody who has a 50% reduction in their overall activity level. So that could mean significantly reduced work capacity or potentially even being unable to work. And severe can mean completely home or bedbound. And I'll talk about that as well in a little bit. 95% of people diagnosed with ME/CFS never return to their previous functioning prior to the trigger or the onset of the condition. Now, when we're talking about long COVID, I'm using the WHO definition of long COVID. So it's a condition or collection of symptoms that occur after 3 months post COVID infection. So you've got to have had symptoms for the 3 months post COVID infection, or sometimes you might have completely recovered from your COVID infection, and then there is an onset of symptoms afterwards, with no other explanation. So we know that long COVID is highly heterogeneous. So it can be just affecting a single organ. Often we find after long COVID, the respiratory system is impacted, or the cardiovascular system is impacted. It can be multi-system, or about 50% of people with long COVID have this kind of whole body, whole system ME/CFS-like presentation. So approximately 50% of people will meet the ME/CFS diagnostic criteria. There is, because it's an emerging condition, we don't have a good idea yet of the permanency of this condition. There is a range of severity also depending on the type of long COVID that you get, and a range of time to remission. Some people we know have not yet reached remission, so it's possible that we might be seeing the ME/CFS kind of stream of long COVID is actually replicating exactly what we see in the rest of the ME/CFS population. We will be focusing on this ME/CFS like long COVID in this presentation. So I won't be touching on the single organ type of long COVID. That approach will probably be quite different to what we're talking about in this presentation. So approximately 3 to 4% of the population live either with ME/CFS or with ME/CFS like long COVID. In Australia, that's the estimate currently. So we're dealing with quite a large but also largely invisible population. But hopefully we will have more well-trained health professionals in the future to deal with this group of people. So talking about that, the different types of severity, here we have a rating scale, a self-rating scale that we ask participants in our courses to rate themselves against, taking into consideration what is a sustainable level of activity for them without increasing their symptoms. So what we're looking at is a percentage of capacity of a healthy adult. So at the top, 100%, that's a healthy adult, fully recovered, normal activity levels with no symptoms. As we're going down, you're looking at mild symptoms, starting to impact activity level. This is the mild spectrum. So they may be able to work or study some hours with difficulty. And this range can be anywhere from about 50 to 90% capacity. Once we hit around the 50% capacity, this is the moderate spectrum. So moderate symptoms may not be able to work. Daily rests are required. They may be able to leave the house a couple of times per week, and only active about 3 to 4 hours a day. It says here physically active, but we're talking about mental, cognitive activity as well. And then down the bottom, 25% of people living with ME/CFS are in this severe to very severe category. These are the people who are mostly or totally housebound or bedbound. And right down the bottom, there are a number of people who are unable to tolerate any exertion whatsoever and are completely bedridden and unable to care for themselves. Now, I've popped some quotes through this presentation from members because I think it really is helpful for highlighting really the disabling nature of these conditions. So here I've got a quote from a member with severe ME/CFS. They say, symptoms fluctuate over time. I've had ME/CFS for 35 years. At times I've been able to cycle 25 kilometers a day, and at other times I've struggled to get up from a chair. And I know in this instance, this member had mild ME/CFS for quite some time, and it progressed to severe ME/CFS. So that's the discrepancy between the cycling 25 kilometers a day and being unable to get up from a chair. I'm going to give you a little bit of a brief overview of the history and kind of social, political research sphere around ME/CFS because this gives you some really good context for the rest of the presentation. So ME/CFS historically has been highly stigmatized. Lots of patients are told that it does not exist, or it is psychosomatic or psychiatric, or they're just being lazy. And this is a really big problem in this area that even now, still today, a lot of health professionals, medical professionals, don't understand the condition and its biological underpinnings. So this is the stigma that they are faced with. There's been very little research. We'll get into the population that it tends to affect, but in this instance, I would hazard a guess that the fact that ME/CFS affects mostly women has a little bit to do with this lack of recognition in the research, lack of funding. Patients are essentially invisible because the severity of the condition means that they may not be able to engage in normal activities. And when they are able to present, because of the fluctuating, remitting, relapsing kind of presentation of the condition, means that they may present fine on one day, and then when they are having the really, really severe payback, then they are not seen in society. Now, I want you just to consider the name chronic fatigue syndrome. When you think of chronic fatigue, what do you think of? Tiredness, just like generally a bit meh. There's a really big problem with this name, chronic fatigue syndrome. It doesn't fully encapsulate the experience and the severity of the condition, which we'll talk about as well later on in this presentation. Unfortunately, at this stage, we don't have anything on the PBS for ME/CFS. We don't have any really good treatment options. There is more research happening in the space, but for many, many decades, there was not. And so people often will have tried off-the-label medications or supplements or some of these weird and wacky solutions. And there's really nothing that good that is very helpful or effective for many, many different people. So we're dealing with a condition where there really isn't any cure, there's no treatment. And most medical professionals are not sufficiently educated on this condition. So many patients will get bounced around, so referred on to a specialist who then says, no, I'm not really interested in dealing with this, or you're too complex, or your blood test results came back normal. So discharged back to the GP who doesn't know how to deal with it either. So they can get bounced around or completely dismissed, or also treated incorrectly. And because of all of this kind of social, political, cultural background, many patients with ME/CFS will have significant medical trauma because of all of this. I do like this little graphic here. Um, your blood test results came back normal. Glug, 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 glug. Um, so why does ME/CFS occur? Everybody has got illnesses, infections, physical, psychological traumas. So why do some people develop ME/CFS and others don't? We don't know. There seems to be a genetic predisposition. We haven't yet totally identified genes, but there seems to be some sort of family heritability. So if you have a parent or a sibling with ME/CFS, then you're more likely to get it yourself. Um, there seems to be something happening with hormones because ME/CFS predominantly affects women, and the onset of the condition usually occurs sometime around puberty. And then if we're looking at this 33 to 39-year-old spectrum, this is kind of the start of perimenopause. So obviously something's going on here, but we don't fully understand it yet. Potentially because of the impact of hormones on the immune system, maybe there are immune differences, maybe there are immune differences within families. We're not 100% sure. And then another theory is potentially some people just have repeated exposure to stressors much more than other people. So if you've had physical or psychological trauma, and then you go and get an infection, maybe you might be at higher risk of developing ME/CFS, as opposed to somebody who might only have experienced one or two stressors. So, not sure, but watch this space. So, diagnosing ME/CFS. I feel like through this presentation, it's going to be, don't know, because also due to this lack of research, we don't have any good biomarkers or anything that we can use to biologically identify ME/CFS. We also have a bit of an issue here with a history of imperfect diagnostic criteria. So the older diagnostic criteria were not specific for that post-exertional malaise of ME/CFS. There was an over-reliance of fatigue, which meant they did not differentiate between fatigue for multiple other reasons. So fatigue associated with depression, fatigue associated with another condition, an autoimmune disease, or something else. So there were probably many people who were diagnosed using the old diagnostic criteria who potentially actually don't have what we classify today as ME/CFS. So this is a big issue also in research because we can't generalize from studies that were run 20, 30, 40 years ago because now we're being a bit more specific about the need for post-exertional malaise, but then there was an over-reliance on fatigue. So the new diagnostic criteria include post-exertional malaise as an essential criteria, which means much higher specificity. It's very unlikely for you to get an ME/CFS diagnosis. That is incorrect. Yeah, so I talked about this older research may not be generalizable to ME/CFS with post-exertional malaise. And this is also a bit of an issue when you come across people as clients or as patients who were diagnosed 40, 50 years ago. They may have been diagnosed using the old criteria that was not specific for post-exertional malaise. So we may need to be screening for post-exertional malaise to make sure that we're actually treating ME/CFS specifically and not some other fatigue-related condition. So here on the right, we have a bunch of clusters of symptoms that are associated with ME/CFS. So at the top, we've got our post-exertional malaise, which I'll talk about. A very common problem is unrefreshing sleep. So somebody will go to sleep in the evening and then wake up in the morning after 10 hours, 11 hours of sleep and still feel absolutely exhausted. There are also other sleep problems. Some people experience insomnia. There may be associated conditions like sleep apnea happening with ME/CFS or severe daytime sleepiness. Um, Kind of talking about this neuroimmune stuff, we've got cognitive problems. So a lot of people will talk about brain fog, being unable to remember certain things, being unable to concentrate, or feeling like they're thinking through mud. We've got pain. Pain is not an essential criteria of ME/CFS. It can occur with it, but some people don't experience pain with ME/CFS. We've got this light sensitivity or other sensory issues, as well as fever and chills. So that's kind of that immune side of things. Abdominal issues are very common, so stomach pain, bloating, nausea. We'll talk about also comorbidities with IBS and endometriosis. And then more of this immune stuff, the sinus, nasal congestion problems, swollen glands, tender lymph nodes, a reoccurring sore throat. So there's something immune going on here. So our more recent diagnostic criteria from the Canadian clinical criteria in 2003 onwards, we've had a few other diagnostic criteria for ME/CFS. These all include PEM as essential. So the commonalities between all of these different diagnostic criteria are that the symptoms must have been present for at least 6 months continuous. You must experience post-exertional malaise. You must have fatigue. There is sleep dysfunction essential in some, and other symptoms such as pain, cognitive impairments, neurological impairments, autonomic dysfunction, thermostatic instability, immune manifestations like we were talking about with that sore throat, flu-like symptoms, as well as food or chemical sensitivities. So these could be also present, but they may not be essential in diagnostic criteria. So what is post-exertional malaise? In a few different places, you might see it called different things. It's also known as post-exertional symptom exacerbation, or PESE, or post-exertional neuroimmune exhaustion, PENE. What this kind of label is actually means is a pathological inability to produce sufficient energy on demand, with prominent symptoms primarily in these neuroimmune regions, and that's part of the international consensus criteria. So minor physical, mental, emotional, or sensory exertion or input results in vastly out of proportion and often severe symptoms. And this is what post-exertional malaise is. The difficulty with post-exertional malaise is that it's difficult to identify because it may be delayed. So it may occur 12 or more hours post-exertion. It might not be immediately after the activity. And then the prolonged symptoms and recovery are key. So typically, somebody will experience these symptoms and have a complete loss of energy for more than 24 hours. It can occur for days, weeks, months, even permanently for some people. What's really key to highlight here is that post-exertional malaise is caused by a pathophysiology. So there is a wealth of evidence now that there are lots of different processes being impacted when somebody is experiencing post-exertional malaise. Um, and also the cause of post-exertional malaise. So we're talking about mitochondrial dysfunction, the inability for ATP to be produced, cardiac neural regulation abnormalities, poor muscle oxygenation, neuroinflammation, reduced cerebral perfusion, the list goes on. And it can affect pretty much every part of a person's body. I do like this one, meet with friends for half an hour and then the next few days. Uh-oh. Now there are articles about the pathophysiology going on behind post-exertional malaise. This is just one paper that talks about a few different aspects of what's going on and has created an interaction model. But there are lots of others, so I highly recommend that if this is of interest to you, to understand the experience and the biological underpinnings of post-exertional malaise and ME/CFS, that you go and search up some of these more recent studies. So I've got some more quotes from members. We've got this one from a member who has moderate ME/CFS. It's like you've got the worst jet lag you've ever had mixed with the flu, but it's like that all the time in your brain and body, all over, everywhere. And when it gets worse, it feels like a living death. And then this member with severe long COVID who experiences PEM talks about PEM. The frustrating and dangerous part about PEM, the fact it doesn't occur until after the event. I often think I managed to have a shower or leave the house without making myself worse, only to wake up 2 days later feeling like I have acid in my veins, muscles aching, head pounding, unable to hold my phone, or sometimes unable to even look out my window. I wonder how long it will last, and know if I try to do anything while I'm like this, I could make it last longer or get worse. I'm just going to talk on a highly controversial topic here about graded exercise therapy in the treatment of ME/CFS. So, graded exercise therapy was previously recommended as a treatment for ME/CFS, but there are issues with the research quality, particularly the larger study on graded exercise therapy. There were a lot of issues with that. So I highly recommend having a read of some criticisms of the PACE trial. And then also high reports of harm. So triggering PEM or actually reducing functional capacity over time. Now, graded exercise therapy, if people don't know what that is, it is a progressive increase in exercise at fixed intervals. So regardless of people's symptoms or capacity, the load of exercise is increased. So this is the major issue for people experiencing post-exertional malaise, because each increase could be re-triggering post-exertional malaise. I just want to say that exercise is going to never be a treatment for ME/CFS or any condition with PEM. That's not to say that it isn't useful for people who have the mild form of ME/CFS. We will talk about ways to use exercise or movement in a therapeutic sense that is appropriate for ME/CFS. But the rationale behind exercise as a treatment was to do with deconditioning, that ME/CFS is a condition that is a condition of deconditioning, and it's not. So PEM is not an issue with deconditioning. Deconditioning is an issue for those with ME/CFS who are very unwell and have been very unwell for a very long time. so are unable to, be upright or be active, but it's actually not the cause of ME/CFS. It's a consequence of living with the condition. Um, the we have many, many people who were athletes, very, very highly active, very engaged members of society who suddenly got ME/CFS or long COVID and were unable to do any of those activities to the level that they did previously. So it's obviously not a cause of ME/CFS. We should always prioritize avoiding PEM and using energy management or pacing strategies instead of exercise therapy. But as I said, over time, some stable ME/CFS patients may be able to slowly add or increase their exercise or physical activity, but it must always be monitored to avoid PEM. I have a quote here from a member with severe long COVID who has post-exertional malaise. And they say, I want to exercise, but I don't want my exercise to mean I can't look after myself or shower. Unfortunately, it often does mean that. I've got a little video here for you.
This video series contains scientific and medical concepts aimed at informing healthcare professionals. Please note that the videos may contain visually stimulating images and movement.
So if you've ever exercised really hard and felt sore 2 days later, that's because you overexerted and your body builds up lactic acid and it has caused some trauma to the muscles and your system. And so your body has to go and repair. In the case of post-exertional malaise, patients will do regular daily activities and have a response that is out of proportion to the activities. And then you go to the therapist and the therapist says, well, we need to do exercise. You're out of shape. You're deconditioned. And that's the problem. And that's where we can cause a lot of harm as therapists. On a cellular level, it's almost like they did heavy weightlifting and then went and ran a marathon while having the flu. So their body has a hard time recovering. Telling them to exercise more and you'll feel better doesn't make sense when even everyday activities causes them to crash. Based on cardiopulmonary exercise testing, they've been able to determine that a subset of patients, their PEM is caused by an issue with getting enough blood back to the heart, so preload failure when they're upright or doing activities. In another subset of patients, they found that their PEM was caused due to the oxygen being unable to be delivered to the mitochondria or due to issues at the level of the mitochondria. The immune system or the inflammation or viral infection can cause damage to the mitochondria, which can affect the body's ability to produce ATP using the Krebs cycle. And so the patient has a damaged or broken aerobic energy system. You're unable to produce the same level of energy that you used to. So patients will try to do activities that they once tolerated, but now they can't produce enough energy for that task. So their body goes into the lactic acid system. Their body starts to glitch, or they start to have all sorts of neurologic and other symptoms. Often patients have been told they're just sensitive, they just need to exercise more, or who have post-exertional malaise, oh, you just need to push through and go for a walk and you'll feel better. But that actually puts them into the lactic acid system where what they once would have felt good with, like a walk around the block, now causes them to deplete all their energy. And so they go into a crash or relapse for several days. So exercise is not something that positively affects these patients. It makes their symptoms worse.
This video was made possible by the OMF-funded Medical Education Resource Center at BHC. Our generous donors.
So that kind of gives you a little bit of an overview of some of the biological issues going on during post-exertional malaise or the causes of post-exertional malaise. I just wanted to talk about the significance of PEM in physiotherapy. So we have an issue here that repeated PEM events, so triggering post-exertional malaise in some people can cause temporary or even permanent worsening of capacity and severity of illness in people with ME/CFS. So avoiding PEM as much as possible is going to be the priority for living with ME/CFS. But what do you do if the exertion from physiotherapy appointments or interventions causes PEM? So I have a couple of quotes here from members about their own experience with physios and PEM. So this member who has moderate to severe ME/CFS says, "I'm scared to go to physios now. Many of them seem to go through the same process. First, they check what I can do and then they add to it. I get sick a few days later, not just with PEM, but also with weird injuries that no one can diagnose. Unfortunately, I tend to be obedient and do as the physio advises, but now it's taking me years to recover." And then this member with severe ME/CFS says, "I used to recover from PEM within 36 hours. Now it causes weeks of physical and cognitive incapacitation." Before we go into actually talking about adapting physiotherapy, there are other complexities on top of post-exertional malaise for people with ME/CFS, and that is these complex comorbidities that often occur. So it's very, very common for somebody with ME/CFS or with a long-standing long COVID to have multiple other issues going on. They may be hormone, immune, or pain conditions. So very common to have endometriosis, fibromyalgia, irritable bowel syndrome, mast cell activation syndrome, or MCAS, or autoimmune diseases. A lot of the time, other people will have complex musculoskeletal or cognitive tissue conditions. So TMJ dysfunction, hypermobility spectrum disorder, or hypermobile Ehlers-Danlos syndrome, so HEDS. Often they might have other neurological conditions or comorbid dysautonomia, which seems to be a really big issue, particularly for people with long COVID. So they may experience migraine, different types of migraine, vestibular issues, spinal cord and brainstem comorbidities. Very, very common in long COVID to have postural orthostatic tachycardia syndrome, or POTS, or orthostatic hypertension or some other kind of dysautonomia. And most people with particularly long-standing ME/CFS or long COVID are likely to have comorbidities. So we're going to have to be very, very careful. Sometimes people may present to physiotherapy for treatment of these comorbidities and then also have ME/CFS. So if you come across people who have these conditions, in the back of your mind, you might always be looking out for the possibility of post-exertional malaise. So ME/CFS and long COVID is a total paradigm shift. It's going to be completely different to treating just about any other chronic condition. And it really involves kind of tweaking what you view as good therapeutic tools when we're talking about limits to exertion. So welcome to the matrix. So let's go on to specific considerations in physiotherapy practice for clients with ME/CFS or long COVID with PEM. So we've already highlighted some issues that may occur when you're seeing somebody with ME/CFS. So they will probably have experienced stigma. A lot of other health professionals that they may have come across don't have a good understanding of their condition. They probably don't have any really good treatment options, so they're feeling quite stuck and um, frustrated and kind of desperate. They may be experiencing high levels of disability. So we're talking about that even mild ME/CFS means a 50% reduction in functional capacity. And their condition can be worsened by any physical exertion, cognitive exertion, emotional exertion, sensory exertion. The list goes on. It includes uh, environmental exertion, orthostatic exertion, just about anything that can impact somebody's body could worsen ME/CFS. And then they also have these complex comorbidities that we're dealing with at the same time. So what do we do? The role of physiotherapy in ME/CFS, there is a few things that we can still provide. We can provide energy management and pacing advice. The number one goal for somebody living with ME/CFS or long COVID should be to stabilize symptoms before introducing anything else. I will toot our own horn and say that this is our own bread and butter. So we do highly encourage people, uh, any allied health medical professionals to refer patients to us for more specific and supportive energy management and pacing advice, because we tailor all of our courses and our education to each patient's, each participant's issues and their own triggers. This can be a really, really complex topic, so I'm actually not going to talk too much about that today, but that is going to be the number one priority. Then pain management. So if people are experiencing pain either from ME/CFS or from comorbidities, physiotherapy can help in this domain. Postural management. So for those who are bedbound or significantly limited, who may be using wheelchairs or spending a lot of time sitting, you can advise on ways to include regular position changes or strategies for pressure area prevention. A big part of all of this might be carer education. So if they are limited to the um, to the extent that they require a carer, getting the carer on board with all of these strategies can be really, really helpful. You may provide suggestions on aids and adaptations, or you may refer to OT for this. Guidance on safe physical activity as part of energy management is also going to be very, very important. And then treating all the comorbid conditions in an ME/CFS aware and safe way. The role you may also play as a clinician might include being an ally and safe space for people who have experienced significant stigma and medical trauma. You might be somebody who can validate the challenging experience of living with significant disability and invisible illness. You hopefully are somebody who is willing to learn from lived experience and provide a partnership in managing an extremely difficult and disabling condition. You may coordinate referrals to further care and be an advocate for your client who has ME/CFS or long COVID. And it's okay to recognize if somebody is too complex for you, specifically in your own tools and professional understanding to manage, and to refer on to other skilled clinicians. And possibly somebody who may see a presentation in clinic and think, that's a bit weird. They seem to be in this post-exertional malaise cycle. You might be somebody who suspects undiagnosed ME/CFS and long COVID and who can refer back to primary care for diagnosis and management. All right, so assessing and minimizing post-exertional malaise. So when we're first assessing for the presence of post-exertional malaise, this may include a very detailed history. So if you're seeing somebody who potentially doesn't have a diagnosis or has a diagnosis of long COVID, but they're not yet aware that they may have post-exertional malaise, there might be a history of an infection. So for instance, in long COVID, we know that they have had a COVID infection. If there is a really weird, bizarre onset, we might be thinking about post-exertional malaise. So this just really comes down to taking a really good history of the condition and how the symptoms may have changed over time. When did they initially present? And are there any weird flares or crashes that seem to happen? So some questions might be, do you find that your symptoms fluctuate a lot during the week or month? Do you tend to get payback for activity? So do you experience crashes or flares after activity? Do you have good days where you're able to do more, but then you pay for it with bad days? And what kind of symptoms do you experience on those bad days? So looking for those neuroimmune manifestations. There are a few ways of using questionnaires to assess for the presence of PEM. So the DePaul symptom questionnaire differentiates PEM from other potentially fatigue-related conditions or depression-associated fatigue. And it also captures other symptoms of ME/CFS. So that's a really helpful one to use. The Horn, oh my gosh, Bateman Horn Center, they created this good day, bad day questionnaire, which can capture the level of functioning on baseline days and then on those PEM days. The FUN-CAP, it stands for functional capacity, 55 or 27. 27 is probably going to be the most easiest for clients to fill out. This captures functioning across multiple different domains, and it is specifically created for ME/CFS and long COVID with PEM. So it captures that delayed post-exertional malaise and impact on functioning. So they're all very helpful questionnaires to use. We do have all of these questionnaires available on our website, on our clinician resources page, if you'd like to check them out. The next thing with addressing PEM might be client education around energy pacing. So PEM is often difficult for the client and also the practitioner to recognize because it may be delayed. So sometimes keeping an activity and symptom log can be helpful. And when we're talking about activity, we're talking about all types of exertion, so physical, mental, and emotional. And then seeing if there's an increase in symptoms within the next couple of days after an activity. What's also quite helpful for clients once they know that they do experience PEM is figuring out their approximate anaerobic threshold and keeping below it by heart rate monitoring. This can be a really helpful tool for clients to get feedback immediately during activity to see if they may be overdoing it. In our courses, we use a equation, which is 220 minus your age and then times by a factor. We use 0.6 for those with kind of moderate symptoms, 0.7, 0.8 for those with mild symptoms, and then 0.5 or 0.4 for really severe symptoms. It's a bit of trial and error. This is an approximate anaerobic threshold. The approximate anaerobic threshold is going to be lower for clients with ME/CFS and long COVID because their aerobic system does not work as well as the healthy population. But it's helpful to kind of experiment with the client to figure out when their when they exceed certain different thresholds for periods of time, does it seem to trigger themselves into a post-exertional malaise state. So like for instance, in my case, my approximate anaerobic threshold turns out to be about 115, 120 using that equation. And I have found through my own experimentation that it's pretty much around that point that if I'm exceeding that during activity, I am much, much more likely to trigger post-exertional malaise the next day. So yeah, it just takes a little bit of experimenting. This is why we highly recommend referring to us because this is pretty much what we do. We work with members to experiment and find their own self-management and pacing strategies. Now, the problem with all of these approaches is that they involve cognitive exertion, so we have to be really careful not to be over-prescribing specific strategies because of the burden that it will have on clients in terms of their own cognitive exertion levels. So yeah, as I said, our organization runs programs to help people figure out their energy envelopes and develop strategies for avoiding PEM. So we highly encourage anybody who doesn't have the capacity to talk about energy pacing in depth with clients, just to refer to us. And we have our Introduction to Pacing YouTube video available on our website as well. I do like this graph, stopping when you get tired, stopping before you get tired, and then after years of experimentation, learning to stop before an invisible threshold that would have given you PEM tomorrow or even a week from now. Yeah, it's hard. It is really, really hard for both clients and practitioners to figure out. Now, other ways that you can minimize PEM is thinking about how you can actually adapt your appointments to reduce the cognitive or physical exertion for clients. So some suggestions might be, rather than having one hour initial consultation or intake, spreading that initial consultation over maybe 4 or 5 shorter sessions. So just tackling a very small part of the picture each time. That can be a way of reducing the exertion for clients. Using handouts or written instructions rather than relying on client memory is very helpful. Considering how you can reduce sensory input. So for instance, turning down lights, being mindful of fragrances and noise. So if you have somebody coming in with ME/CFS, or long COVID, thinking about, oh, potentially I won't put on my perfume today. Starting with very, very minimal interventions and then assessing any increase in symptoms. So being very, very cautious about our approach to interventions and treatment. Being mindful of client posture. So inviting them to lie down or recline for most of the session if available, or if they are sat in a chair, giving them the opportunity to put their feet up on a footstool or on something else. So it reduces that orthostatic exertion. Really helpful for those on the kind of more severe spectrum, providing telehealth or home visit appointments can be very helpful. And rescheduling appointments and being flexible if a client is already in PEM. If they're in PEM, it is not appropriate to be encouraging any attendance at appointments. They really need to be focusing on rest and recovery. So small quotes. A member with moderate to severe ME/CFS said, I may need to lie down during appointments and close the curtains to block the light. I need short appointments and minimal chit chat. And then a member with severe to very severe ME/CFS said, I am in PEM every week for years. The odd day it eases a bit. The finest, tiniest thing makes it worse. I always feel that I have the worst flu you can imagine, but it never goes away. plus being poisoned at the same time. Tiny things make it worse. Someone speaking too quickly, touch that's too hard, walking from my bed where I lived 24/7 for years to the bathroom more times than usual. But yet I still need healthcare. I've still had to have some physiotherapy at home help. We had to communicate in text before the appointment. The hands-on part was only 15 minutes, etc. My physio learned to speak softly and slowly. We had to prioritize what was absolutely critical for her treatment versus impact on my CFS. Another part of treating somebody who's got post-exertional malaise is to recognize the client as a whole human, and that there may be many other outside triggers that contribute to a lower threshold for post-exertional malaise on any particular day. And that might include weather or seasonal changes, trialing new medications, hormonal fluctuations. So if a client is perimenopausal or is experiencing their menstrual cycle or puberty, emotional stress from finances, relationships, medical uncertainty. This condition really increases stress, unfortunately. Other conditions, for example, if somebody has uncontrolled blood glucose, that could really contribute to post-exertional malaise. Any current infections they may have, cognitive exertion. So if they still work or study, they may have a lowered threshold for cognitive exertion. And then during these periods of higher load, it may not be appropriate to add any therapies. And so we instead focus on stabilization. Assessing an intervention is not causing PEM. So we really want to be constantly asking and thinking about a symptom load since introducing an interventional treatment, and remembering that it may not occur immediately afterwards, and it may be like a collection of things putting somebody over a threshold. So I'm thinking about the entire time that they since this interventional treatment. So have they experienced increased symptoms during this period? And particularly looking for post-exertional malaise symptoms, so fevers, fatigue, nausea, cognitive dysfunction, reduced tolerability of sensory input, and really recognizing that clients are experts in their own bodily sensations and experience. So really asking them, are they what is their gut instinct around this? Do they think that they're actually tolerating it, or are they experiencing a bit more of this up and down since? So again, a symptom and activity diary can be helpful. Post-exertional malaise is often reflected in a decreased heart rate variability and a increased resting heart rate. So if they use a smartwatch, has there been this decrease in heart rate variability or increase in resting heart rate since the interventional treatment? And that may suggest that what you've introduced may be too much. And PEM often also impacts sleep quality. So you can assess this by sleep scores on a smartwatch. Has there been kind of a dip in sleep quality overnight? Reports of insomnia. A lot of people who are in PEM experience insomnia or disrupted sleep-wake cycles. And if the interventional treatment may have caused PEM, reducing it by 50% is the first strategy, and then reassessing. Another quote from a member with moderate ME/CFS. Sometimes even going to the appointment is enough to trigger PEM. It makes it hard to know if the program or leaving the house is what caused it. And this just kind of speaks to the complexity of living with this condition. So we've kind of covered the basics of PEM. Now let's talk about assessing and treating pain. So like I said, there's high comorbidity of other pain conditions with ME/CFS. So fibro, migraine, IBS, endometriosis, autoimmune arthritis, hypermobility disorders, TMJ dysfunction. Pain can also be a PEM symptom. So asking your client, do you tend to experience pain as like a payback symptom? Or it could be an injury that can occur for many different reasons. Um, a couple of helpful scales for assessing the level of pain are the Mankowski pain scale. So this is assessing the pain on a 0 to 10 scale, but it gives descriptions for the impact on function and the required pain medication use, which can be a lot more, I guess, objective than some of the just score your pain on a 1 to 10. Speaking of scoring your pain 1 to 10, the visual analog scale is a continuous 10-centimeter line from no pain to worst imaginable pain. They can be used as well. Treating pain when a client experiences PEM is going to be difficult, but it should always be the goal. So some of the most recent evidence-based interventions for chronic pain in particular are more active strategies, but they may not be so appropriate for somebody with post-exertional malaise. So it's actually okay to use passive strategies in this case. So things like manual therapy, such as mobilization or massage, dry needling if they tolerate it, stabilization for hypermobility, so taping and bracing. And then exercise can be a useful tool, but just caution, again, while wanting to prevent post-exertional malaise. So considering low rep and functional reclined mobility exercises first to assess response. Clients with pain anecdotally tend to respond well to heat and or TENS, but of course everybody's different. So it'll be a bit of a trial and error again. And I know this is typically not the case in treating lots of other conditions, but because of the risks around post-exertional malaise, it's actually okay for intermittent long-term manual therapy for those who do not tolerate those more active approaches. Assessing and treating comorbid dysautonomia or orthostatic intolerance. So there are a few different ways of assessing if somebody has orthostatic intolerance or POTS. We typically use either the NASA lean test or the active stand test. This is a passive standing test to assess for orthostatic intolerance. It may trigger PEM in some people, but the toss-up will be discovering if there is actually POTS or orthostatic hypotension happening at the same time, and then being able to treat that may reduce the burden on the ME/CFS as well. So it can be even for somebody who may experience PEM as a result, it could sometimes still be worth it. So again, talking with the client, discussing risks. There is a questionnaire called the Compass 31, which is the Composite Autonomic Symptom Score. It assesses lots of different domains of autonomic dysfunction and severity, and this talks about in addition to that orthostatic issue, it also talks about things like gastrointestinal autonomic symptoms and others as well. So treatment for dysautonomia or orthostatic intolerance might include manual compression for POTS or orthostatic intolerance. If possible, referring on to specialists for pharmaceutical management. The gold standard initial intervention is usually an increase in fluids and salts, but again, this needs to be done under supervision of a medical practitioner. A supine exercise program is often recommended, but again, this needs to be adapted for post-exertional malaise. And then, as I said, they may need to be referred to a neurologist or cardiologist for assessment and management. But unfortunately, we have a lack of autonomic specialists in Canberra, so they may be referred interstate. And just as a note, POTS can actually be diagnosed by a GP. So if you suspect POTS, you can refer back to primary care. Okay. And then assessing and treating other symptoms. So comorbid hypermobility. You can use the 5-point questionnaire for generalized joint hypermobility. This is not going to capture everybody. But again, in your own clinical expertise, you may notice that somebody has joint hypermobility or that they demonstrate other symptoms of a connective tissue disorder, in which case you may be referring again back to primary care or onto a specialist. Joint or muscle support, such as splinting, bracing, taping, may reduce pain for those clients who experience hypermobility. They may have undiagnosed hypermobility disorders, so will require further investigation. And a history of subluxations may be present. So again, training through body awareness and safe range of motion, all that kind of education can be very helpful. But again, taking it very, very gentle and very slow. Dysfunctional breathing. So breathlessness or air hunger is a common issue in both ME/CFS and long COVID. People with long COVID may also have issues with breathing due to lung damage from their COVID infection. So both may benefit from gentle chest physiotherapy or breathing rehabilitation, or even just education around diaphragmatic breathing exercises and things like that. Again, introducing very low and slow. And sleep dysfunction. So this often results from the neurological, immunological, and cellular changes in ME/CFS. And the sleep dysfunction can actually be an indicator of the experience of post-exertional malaise. There is often a high level of sleep apnea comorbidities, so they should be referred for assessment from a sleep physician. Common sleep hygiene practices will not be suitable for ME/CFS. For instance, getting enough exercise, etc. So the focus should be actually tailored to the client. And it might be just things like regular bedtime and being able to increase stability in symptoms and reduce PEM might actually improve the sleep dysfunction as well. So to summarize, physiotherapy for ME/CFS should focus on the specific goals of the client and empower them to direct the direction of treatment. Identify triggers for symptom exacerbation and make sure the management plan is adapted to avoid these. Consider the most appropriate measurements of the person's response to the management plan, prioritizing above all else, avoiding PEM. It may be creative, should be person-centered and compassionate, and physiotherapy can always refer on if warranted. Now we're just about at the end of the presentation. I've got some resources here for physiotherapists. So I highly relied on this book on the left, A Physiotherapist's Guide to Understanding and Managing ME/CFS, which was published in 2023. It includes some info on post-viral syndromes as well and long COVID. It's a really, really good comprehensive resource. I've touched on some introductory stuff in this talk, but this book goes into a lot more depth around it. So I highly recommend purchasing a copy for your practice and giving it a good read. The authors who created this book work for Physios for ME in the UK. So they have a good range of resources on their website as well. That's physiosforme.com. Emerge Australia, which is the peak national body for patient resources for ME, CFS and long COVID. They have got a CPD program for medical and allied health professionals. So there are lots of really good resources on there as well, and there's more coming out every month or so. So I highly recommend checking that out and signing up for those CPD webinars. We have got our own resources for clinicians webpage, which is linked there. I'm going to be continuing to add to it as well, so there will be more resources in the future. And then another really good resource is, again, this is where that YouTube video was from, the Bateman Horn Centre YouTube playlist for physical and occupational therapy and post-exertional malaise. And they have some really good introductory resources on there too. Again, we really welcome referrals for our self-management courses and other services. For us, it's really important to be educating and empowering patients to kind of take their own self-management into their own hands, as well as feeling comfortable advocating for themselves. We highly encourage people to refer to us specifically for that pacing and self-management education. But we also have support groups, all sorts of talks, education, fun activities and things like that as well for members. So please do contact us. Our email is mecfs@arthritisact.org.au, or you can call reception at Arthritis Pain Support and Emerge ACT. And this is our webpage here. So if you go to Arthritis Pain Support Emerge ACT.org.au and you click on the Emerge ACT logo, it takes you to our services page that has got information about all the sorts of different services that we run for members. I'm always also happy to talk to clinicians as well. Send us an email and I can give you a call. And then as we finish up this presentation, I just wanted to credit my references, particularly Emerge ACT members and staff who contributed to this presentation. We had some input from our two physiotherapists, so Nick Van Diemen and Karen Rick. And then also I have presented this presentation to our exercise physiology and exercise science team, and they have provided some feedback as well. Again, this presentation very heavily relied on that book, A Physiotherapist's Guide to Understanding and Managing ME/CFS, but I've listed other resources that I've used here, and then also on the next page. That's all for today. Please do get in touch if you need more support or you'd like to refer clients on to us. And thank you so much for considering how you can improve your own practice for people living with ME/CFS and long COVID.